experts of the hemodynamic group to present the statements regarding this topic, and I have the following conflicts of interest. And by the way, you know that all the conflicts of interest of all the experts may be found on the website. These are the picker questions we had to address in our group. When should one monitor cardiac output in shock? How should one monitor cardiac output? When should one monitor arterial pressure? What is the target of arterial pressure in shock? When should one monitor central venous pressure in shock? And when should one monitor intra-abdominal pressure in shock? The two last picker questions have been added compared to the 2014 recommendations. Regarding the first statement, which is, so when should one monitor cardiac output in shock, the literature search found 12 studies that fulfilled eligibility criteria. These were RCTs, so that mainly compared cardiac output monitoring versus no cardiac output monitoring. There was one retrospective study that fulfilled the quality criteria, which means that it was based on a large database. Regarding all these studies, many of them had not mortality at an endpoint, and none of them showed a difference in mortality. And so this led us to the following statements regarding the issue of when should one monitor cardiac output. We suggested to recommend monitoring cardiac output and/or stroke volume in patients who do not respond to initial therapy, and the aim is to assess the type of shock, the hemodynamic status, and to evaluate the response to therapy. And this is an ungraded best practice statement, which means that in the grade system, it is not possible to grade such a recommendation. And this refers to the issue that has been already mentioned by the previous speakers. To say that simply, yes, we must use the grade system, as said by Antonio Messina, in order to have consistent recommendations. Nevertheless, the grade system, if there is no effect on mortality, you cannot grade, or if there are, which is different, but if you have different results on mortality. And the problem is that for such recommendations, such issues, for instance, cardiac output monitoring, I guess there will never be any study showing any effect on mortality, so it must be an ungraded best practice statement. Another point which is very important to consider regarding all the statements is that the methodology has been changed compared to the previous consensus conference. That's why the grading and the level of grades has changed compared to the previous 2014 recommendations. And that's very important to consider if you look at the two different versions. So here we recommend monitoring cardiac output and stroke volume, not in all patients, but likely the most severe patients, not only because they are severe, because you want to understand what happens and what are the effects of the treatments in these patients. The second statement is to redo evaluation, to repeat evaluation. We suggest serial evaluation of the hemodynamic status during shock, so it's not only one time a day, it's regular or serial evaluation in these patients. Still on the same PICO, we stated that when cardiac output is monitored, we recommend that it should be interpreted in regarding its adequacy, and this adequacy should be evaluated by assessing organ function, tissue oxygenation, metabolism, and peripheral perfusion. And of course, it is based on the very basic physiology, A value of cardiac output should not be interpreted alone. It should be interpreted with all the elements, and there are several elements from cell metabolism to skin perfusion that help you assess whether cardiac output is enough or not. By the way, and again I state as the previous speakers that these are provisional statements that may be modified before publication of the recommendation, of course. And finally, regarding the speaker, we recommended performing serial echocardiography to provide additional information on cardiac function even when cardiac output is monitored. And that's a very important statement that really reflects the way the experts thought about this way of evaluating hemodynamic status. I mean that it's not cardiac output monitoring devices versus echocardiography. It must be a combined practice. It must be a combined assessment. If you use any of the devices that help you measure cardiac output regularly, you must use echo in addition because echo is the best way to assess cardiac function as stated in this statement. The second PICO was regarding the ways to monitor cardiac output in shock patients. Much less studies, 5 RCTs. Nevertheless, one only really compared 2 different devices in terms of outcome. There was no difference in mortality in this study, in this RCT, that compared PICO versus pulmonary artery catheter. We stated that we suggest using transpulmonary thermodilation or the PA catheter in patients for whom cardiac output monitoring is required. I'm sorry, one word is missing. So the patients that were described in the previous statements. We suggest using transpulmonary thermodilation or PA catheter in patients with shock and moderate to severe ARDS for guiding fluid therapy. And the experts thought that one of the main interests, or likely the main interest of monitoring in these severe or moderate to severe ARDS patients would be to guide fluid therapy. And we added 2 remarks. The first is in patients without right ventricular failure, transpulmonary thermodilation is preferred for the measurement of extravascular lung water. And remark 2, in patients with right ventricular failure, the pulmonary artery catheter is preferred for the measurement of pulmonary artery pressure. These 2 remarks have been added compared to the previous recommendation to clearly state the potential advantages of both types of monitoring. A new statement also would be that we suggest using the pulmonary artery catheter in patients with persistent shock and right ventricular failure after cardiac surgery in addition to serial echocardiography. And you know that it's a quite common practice to use the PA catheter in such context. A statement regarding echocardiography, in addition to the statements that will be stated later by Oliver Hunziker. We suggest that when devices, it's not about echo, this one, I'm sorry. We suggest that when devices less invasive than pulmonary artery catheter and TPTD are used, transpulmonary thermodilation are used, they should have been validated in the context of patients with shock. And that's, of course, a very important statement. We have new devices that appear regularly on the market. Before you use it for these most severe patients, I mean patients with shock, you should assess whether they have been evaluated in such patients regarding the reliability of cardiac output monitoring. And this is the echo statement I spoke about. We recommend using echocardiography as the first-line modality to assess the type of shock and hemodynamic status. So it means that at the initial phase, we definitely think that echocardiography is mandatory initially to understand the hemodynamic status through all the information it provides regarding cardiac function, cardiac structure. Regarding when should one monitor arterial pressure in shock patients, we recommend continuous monitoring of arterial pressure in shock, and this is typically an example where it is an ungraded best practice statement. I mean that there is no study that compared arterial pressure monitoring versus no arterial pressure monitoring. In spite of that, because of evidence, because of physiology, we think it's a recommendation. We recommend and do not simply suggest continuous monitoring of arterial pressure. And also we recommend invasive monitoring of arterial pressure in shock that is not responsive to initial therapy and or requiring vasopressor infusion. Likely the rationales, the text that will accompany these statements will detail that perhaps in case of very small doses vasopressors, the things may be different, but this is basically the statement and the recommendation, again, an ungraded best practice statement. We've had a lot of discussions regarding the target of arterial pressure in shock patients. The literature search has found 15 studies, RCTs, but also retrospective analysis of large databases, one observational study, and also post hoc analysis of previous RCTs. You will find in the final version the different studies that have been considered. And some of these studies have been eventually removed because they were not conducted in shock patients. We recommend that the target blood pressure should be individualized during resuscitation of patients with shock, personalization of the target. We recommend targeting an initial mean arterial pressure of 65 and more in patients with septic shock. We suggest using a higher MAP target in septic patients with a history of hypertension that show clinical improvement with higher blood pressure. And we had a lot of discussions about that. As you know, the literature is contradictory. Some studies, and especially subgroup analyses, have suggested that there is a benefit in hypertensive patients to increase the MAP target, but it's not been found by some other studies, and there was no effect on mortality, and that's why it remains an ungraded best practice statement. We suggest, again, using a higher MAP target in septic patients with high CVP values that show clinical improvement with higher blood pressure. By the way, it means that if your patient is okay while you targeted a lower MAP value, it means that you should still use this lower MAP value, but if the patient does not improve and has high CVP, we suggest using a higher target. We suggest lower targets of MAP in patients with traumatic hemorrhagic shock and uncontrolled bleeding in the absence of traumatic brain injury, and the quality evidence of the literature was judged very low. In patients with traumatic hemorrhagic shock, TBI, so traumatic brain injury, and coma, so Glasgow Coma Scale below 8, we suggest targeting an initial systolic arterial pressure above 90 millimeters of mercury, and these statements regarding trauma patients are consistent with the recent European recommendations in trauma. The two last statements, the two last speakers, I'm sorry, about first, target of arterial pressure. We suggest to target an initial map of 65 and more in patients with cardiogenic shock. Again, it's a low quality of evidence. So I was saying the two last speakers, CVP and intra-abdominal pressure monitoring. Regarding CVP, 4 studies fulfilled the eligibility criteria. These were all RCTs, and 1 was excluded because it was not all the patients that had shock in this study. And the literature analysis led to the following statements. We recommend measuring CVP in patients with shock who have a central venous catheter. And we think it is a very important statement. Again, it was not present in the previous recommendation. We insist on the value of central venous pressure in shock patients, at least when a central venous catheter is present. And we do not recommend targeting a pre-specified CVP value during the resuscitation of patients with shock. We do not recommend to target a specific CVP value. Finally, regarding the intra-abdominal pressure measurement, when should one monitor intra-abdominal pressure in shock? Very few studies, and that led to this recommendation. We suggest monitoring intra-abdominal pressure in patients with shock and risk factors for intra-abdominal hypertension. And of course, the text that will accompany this statement will detail these risk factors, the patients where intra-abdominal pressure should be monitored. So these are the statements regarding hemodynamic monitoring. I would like, before ending, to really warmly thank all the experts that participated in this consensus conference. And with Michel Chu, we were really very happy to work with all of them. It's been a great job, and I was really impressed by the will of everyone to reach a consensus. As you guess, it's not easy with such experts in the group. By the way, this list of experts has been done by considering the level of expertise of the experts. And we thought at the beginning that it was very important to have rules for recruiting the experts, and we considered the number of publications of the experts in each field covered by the consensus conference. So it means that we not recruited experts because they are friends, because they are just well-known. We really considered the level of expertise, and as it is the case for all the consensus conferences of the Society, we also included two young members of NEXT. A special thanks to Michel Chu, of course, my co-chair, but also Jan Bakker and Antonio Messina, so the leaders of the different groups. And a big thank you to Massimiliano Greco. It was funny because when he presented the methodology, he always said, we have analyzed 3,000 articles. No, he analyzed, and he was the only one to do that. So you can imagine the amount of work that it's been. Thank you very much for your attention.
Thank you very much, Xavier.